Stamm. Thank you.
Good morning, everybody. It's noon already. It's past noon. I'm sorry. So, good afternoon. My name is Christoph Stamm. I'd like to thank the organizers for giving me the opportunity to put my 2 cents worth into this discussion here. And what Paris, I think, did not mention when he introduced me is that I'm a surgeon. And as a surgeon, your mindset sort of obliges you or forces you to make up your mind to come up with a decision at some point. You cannot go on operating forever and changing something and do something and do something. No, at some point you need to decide whether something works or not. And I've been working in the field of tissue engineering and regeneration for 30 years, and I've come to that point, and what decision I made you will know by the end of this talk. So, biologic implants, of course, classic biologic heart valves in the pediatric cardiac surgical field are known to not function so well. They deteriorate, they degenerate rapidly. We all know that. But nevertheless, in the past years, a lot of other things have come up in our field that have sort of biologic overlaps with biologic heart valves, namely these patches. These patches are widely used for repairing defects in children and so on. And there is another thing that changed a lot this year, the catheter-based valves, which in the pediatric cardiology field have been around for a long time, and few people really took notice of that. But now that they have become widespread use in the adult cardiology field, things have changed to some extent. So I have been given the task to discuss degeneration versus regeneration in the context of pediatric heart valve surgery, heart valve replacement. And I would like to start with degeneration. So basically, I've said already, we all know that biologic heart valves, tissue heart valves in children don't work quite well. This is a recent series here, I think from Austria. It's only a year old. It essentially shows what has been known for decades now. If you put in a biologic heart valve replacement in a child, it'll fail within a few years. Mechanical valves work longer, but with obviously their intrinsic problems in terms of coagulation and also obviously no growth. What is also interesting is shown here in this review paper from France. They compared homografts with autografts. That's also not really new, but I find it very illustrating that if you look at the homograft survival curve in children, they do quite well for nearly 8 years. So they are treated by our body like an autograft, but then they fail. Then something happens that essentially induces failure of these human but not individual identical valves. So, as I've already alluded to, a lot has changed. I was surprised when I Googled information for this presentation, how much research is all of a sudden going on again regarding structural valve degeneration. All of a sudden, all the big major cardiology groups are putting out papers and statements and guidelines and what have you. And this is all triggered by what you can see here, bioprosthetic heart valves, upgrading a 50-year-old technology, transcatheter valves. So TAVI has triggered a lot of effort. All of a sudden, even adult cardiologists don't consider a deteriorating biological valve just the surgeon's problem, but they developed an intrinsic interest by themselves on their own. So there is now a definition here, a classification for structural valve degeneration. You can see here, obviously you can classify anything into an infinite number of steps if you want. Even the imaging people are now part of it. They have dedicated papers, reviews, a lot of output is going on trying to image degeneration and various types of degeneration of tissue valves. So surprisingly much is going on, but surprisingly little really new has come up within the past years. So as we all know, the overall mechanism that lead to structural valve deterioration prosthesis-related calcification. So this is essentially calcium entering the tissue before you put it into the patient, mainly due to the treatment process of the tissue. This is then followed after implantation by the recipient-related dystrophic calcification. There are always and will always be structural differences between native and artificial valves, at least with a standard biologic prosthesis on a scaffold. These differences are very pronounced. The relationship between mechanical stress and calcification is a big issue. I think to some point, and Viola also alluded to that. The cyclic loading as a major determinant of mechanical degeneration is a point. The unspecific foreign body reaction and Ponners growth is also something that plays a role. And then last but not least, the immune filtration into the valve tissues and also in case of xenogenic tissue, the immune response against a xenograft. So you can further look into this into much greater detail, mechanical contributions, chemical contributions, immunological contributions, and they all lead eventually to valve failure. This has been reiterated many, many times. If you look at the timeline here, this is a picture from a review from China that I found that is actually quite nice. I think the native tissue here is obviously everything's fine. Then you prepare a biologic heart valve in vitro in the factory, and by doing so you start degrading the tissue, degrading the matrix. You obviously kill the cells, or you even try to remove the cells. Then you implant the then you implant the valve, and then the fun really starts. Then things from the blood move into the tissue that are not supposed to be there, and they introduce inflammatory cell responses, antibody responses, and so on, eventually leading to progressive calcification, and at the end also possibly to thrombus formation on the surface of the valves. So why is that, and why is it so bad in children, much worse than in adults? This has never really been clarified. We used to say, okay, it's the metabolic rate. Children have a much higher metabolic rate, whatever you understand by that, than adults, and that's why tissue valves fail earlier. So metabolism, the metabolic rate, is essentially how much substrate in terms of energy we metabolize. And this has never really been quantified over a lifetime. But there is a recent study here. They used, you see, the IAEA, the International Atomic Energy Agency, was also involved. They used sort of radioactive water, if you want, an isotope, a water molecule containing a hydrogen isotope and an oxygen isotope. And by taking this up, this gets integrated into all sorts of things, and eventually, by some way that I cannot explain to you in detail, you are able to really quantify the metabolic rate in an individual, and that in individuals of various ages gives you an idea of the lifetime changes in metabolism. And yes, it has confirmed what we all know, that children, infants and children, have a much higher metabolic rate per non-fat tissue. That's how they normalize it, than adults. One interesting thing, by the way, is this here. You see, we get born with a very high metabolic rate, which then decreases by 3% a year until we're adults, and then it stays constant. So I used to tell my wife, at the age of 40 or now over 50, I'm not in the same shape as I was when I was 20 because my metabolic rate inevitably declines. But unfortunately, that excuse cannot be used any longer. Metabolic rate actually stays constant, stays stable in adulthood until we reach advanced age, and then it drops. What has not been in the focus of research for some time is the immune system. And that is something that is being reconsidered now. It has become clear that the immune system in structural valve deterioration has long been considered with skepticism, as this author here said, because we fix it with glutaraldehyde, and we used to believe that this eliminates essentially all immunogenicity by degrading and cross-linking all the structures or the epitopes that may be immunologically active. Well, this is not the case, and that is something that has become very clear in the more recent past. For instance, if you look at this here, if immunology is so important, why not just give patients immunosuppressants? Well, yes, it can be done, and it does work. There's a report here from Japan in younger patients that received biologic valve replacements in the setting of an arteritis, of vascular inflammation, so they needed to be on steroid for long term. And indeed, tissue valves last much longer in patients on steroids than in patients with a normal, non-suppressed immune system. But obviously, this is not really a solution. We cannot put every heart valve recipient's lifetime on steroids. So this has been our traditional conception of the immune system over a lifetime. We are born with some innate immune activity and also with maternal antibodies. But apart from this, we're sort of immunocompromised in childhood because our adaptive immune system has to develop first. So we start with little immune activity, and this goes up in the first 2 decades of life until it reaches a stable plateau, and by the end of life it declines again. So this was our conception still, you see here, 7 years ago. This has changed recently, thanks, I must say thanks, also it's not really something to be grateful for, with the onset of COVID-19, I'm sorry, all of a sudden a lot of research was done in immunology in the pediatric field because it became clear very quickly that children are not affected by COVID-19 as bad as adults. Obviously, they have a better immune response, although they don't have much of an adaptive immune system yet at that point. So a lot of research, a lot of energy, a lot of researchers of resources are being put into that field, pediatric immunology, and it has become clear recently that with the time of birth, we already do have a significant degree of immune activity in our system that is much higher than we used to believe. And this, I think, is part of the explanation of why in the pediatric setting tissue valves fail so early. At the BIH Center for Regeneration, we have a very active researcher, Martina Seifert, a good friend of mine. She has been working on immunogenicity of extracellular matrix in heart valves for nearly 20 years. This hasn't received much attention, at least not in our immediate community, but she has published a lot, and she has a lot of insight and found many things, as you can see here by the various titles of just some of her papers. To sum it up, what she found was that individual allo- or xenogenic matrix components, elastin, collagen, in isolation, do not elicit a relevant immune response in vitro, that's clear. But intact xenomatrix a decellularized heart valve from a pig, they do elicit quite a strong immune response, but that can maybe be suppressed, at least by some degree, by modifications, coating, adding other things. And intact human matrix, allomatrix, things like the decellularized homographs that we can purchase or get implanted in Hanover, elicit also some immune response, which may be eliminated completely by treating the valve somehow. Well, there is, however, there are built-in shortcomings to all of these data. First of all, or the vast majority of these data were obtained in vitro. They were obtained in models that basically resemble short-term. Even 6 weeks in a dish, half a year in an animal is nothing compared to the lifetime of a patient. Mechanics, well, we just heard from Viola a lot about mechanics and how we can try to mimic this in the dish or in the pulse duplicator system. Yes, it is an attempt, but it obviously is far from reflecting what goes on in terms of mechanics in the human body. If there are in vivo data, then there are obviously animal models, very rarely human, at least no models, just observations. We only check selected immune components. We only have a limited number of outcomes, of readouts, of cytokines, of cell activation, whatever. We never get the whole picture. We can only look at individual little things. And this is one important thing, in most of these assays here, the immune cells that are used for measuring the activity of the response are from adults. Very few people have access to pediatric cells for experimentation. So most of the data may be valid to some extent for adults, but not for children. As I've mentioned, my group has been involved in this field also for some time here, and one of the most simple first attempts that we did is we decellularized a heart valve, porcine heart valve. Here, took all the cells out, you all know, and then we sort of hid the matrix by coating it with polyhydroxybutyrate derivative, and we implanted these hybrid valves in sheep for 12 weeks and found and observed really nice valves after a quarter of a year. So it does work, and in vitro you can see that, yes, this treatment sort of improves hemocompatibility and reduces immunogenicity of the decellularized valves. So this is one possibility, but it's very crude, and mind you, this is a biodegradable polymer, so at some point it will be gone. We want it to be gone, but once it's gone, the matrix will be exposed again and immunology will start. We can elaborate on this. We mixed sort of biologic components to this scaffold, to the coating, to make it more similar to the human situation. And yes, we did measure in all these assays some positive results, but yet I'm not convinced that this will really change anything. Here is a very recent example from Philadelphia. Again, they came up with something they realized, as has been known for some time in the field of atherosclerosis, that are these age things, advanced glycation and products. For those who are interested in the difference between glycation and glycolization, one is with an enzyme and the other is not. And this here gives you these things, and they are very bad, and they migrate, they move into the scaffold, into the tissue, and they induce all sorts of harmful biologic processes. And with a certain treatment, with a certain coating here, can I go back once? Yeah. Here they were able to show, yes, that this reduces immunogenicity of the matrix significantly, but yet again, this study, although is very high, was published in a very high-ranking journal and so on, is largely in vitro and far from large animal stage, even much further from being applied to humans. So this is the news, if you will, on degeneration, which is not much news. Now, what about regeneration, the interplay, or call it the fight, the struggle between degeneration and regeneration? Well, you all know these images here, the Fountain of Youth and Prometheus, and I have been showing these images for 20 years and telling people that regenerating is the future. Okay. We all say children regenerate much better. They have a much higher potential for intrinsic regeneration. But is that really true? This is the brain of a child with cerebral palsy. There is no degeneration. The brain just dies and scars after ischemic injury, just as it does in an adult. Obviously, a young child then can make more with half a brain than an old person. But the other half will still be gone and does not regenerate. Hearts, I mean, this is just one example of a child with some kind of heart failure on an XCOR assist device. We all know once the heart has failed, unless it's something temporary, like myocarditis, but if the myocardium has really failed, then it does not recover, no matter how young the child is, not even in newborns. It does not happen. And this is a heart valve here, a mitral heart valve. Rheumatic heart disease. Has any surgeon ever observed at least some evidence of a heart valve repairing, regenerating spontaneously? No, it does not exist. What's dead is dead, and that is true for the child as well as for the older person. What does work is this here, bone healing. Oops, I'm sorry. Bone healing here, a femur essentially destroyed at the time of birth, heals within 2 months, a few weeks. So this works, but this is intrinsic healing. This is not regeneration. This is wound healing when nature has supplied us with a tremendous repair capability. But this is bone, not heart. We can sort of induce regeneration. You've just seen many, many examples from the Zurich lab. We can seed cells, endothelial cells, stem cells, smooth muscle cells, what name you. A lot can be done to at least temporarily add some cells to a valve scaffold, yes? But this still, again, in my opinion, does not change the overall outlook. So this is a paper, I mean, you've seen images of this before from Dr. Vogel from the Zurich group, a review by very esteemed colleagues, some of our own institution here, and they again show tissue engineering, what needs to be done. It gets very complex. The title is Next Generation. Tissue engineering will maybe make a difference. My question is, how many generations yet? This next generation, I've been seeing on slides, on papers for more than 30 years in the field of heart valve tissue and engineering. And nobody can tell me when the ultimate generation is going to come about. My opinion now is it never will. So keep on dreaming. In summary, I strongly believe that the immune response to whatever foreign body, foreign material, foreign molecule you put into a child's bloodstream will always outweigh regeneration. And that is a good thing. The immune response is fast and life-saving because we're constantly threatened by viruses and bacteria, whereas only few of us have actual issues with their heart valves. Yeah, so it makes a lot of sense. Regeneration is slow and much less important than dying from an infection. Expecting regeneration while triggering the immune system, and we always do that when we put something in that is not autologous, is futile. The immune system itself cannot be manipulated at will. We can suppress it somehow. Of course, nowadays we have very elaborate methods to also manipulate certain components, but nothing has yet helped to eliminate the immune response to putting in a heart valve. Overall, I believe, unfortunately, regenerative medicine and tissue engineering are overrated. I would recommend you to forget regenerative medicine, tissue engineering, cell therapy. It is never going to work, at least not in the heart. Forget intrinsic regeneration as well. This is something that happens in bones, yes, and there we simply call it healing, and we don't need this big word regeneration for it. So, the final slide, the eternal struggle, degeneration versus regeneration, the immune response versus regeneration. The immune system will always win and will eliminate the success of whatever effort we make. Thank you very much.
Thanks, Christoph. Great talk with a very provocative end. And I conclude, if you say forget about regeneration, then we should kind of try to slow down the way on degeneration, let's say our way on degeneration, and stay in homeostasis as long as possible. I would like to come back to that friend of yours, Mrs. Seifert.
Yeah, Martina.
So you said if there's intact synogenic material, this kind of elicits immune response. If there is intact allogenic material, the immune response is less.
Yeah, but it is there.
Yeah, but it is there, exactly. But you didn't tell or mention what happens if there is intact autologous material. Did she kind of investigate that?
Well, I mean, at least until recently, not so many people have looked into the immunogenicity of autologous tissue because it's autologous tissue. But by doing what you do, and we will hear about that soon, I hope, you manipulate the tissue somehow, which may then secondarily induce some kind of immune response, yes. But on the other hand, I mean, the perfect example is the Ross operation. You take the valve from the pulmonary position, you put it into the aortic position, and nothing happens in terms of immunology. It heals, it grows, it's viable, and so on. It works perfectly, yeah? So autologous is the gold standard. I would say go for autologous if it works, if your approach will work, and if not, then go for artificial things, mechanical things, mechanical valves that we will hear about, I think, from Dr. Imani, that are some kind of a polymer, just dealing with physics, with mechanics, with materials that humans have made is much more controllable than trying to do something with biologic tissues.
Thanks, Christoph. Excellent talk. And I completely agree. There's a lot of myth and excitement about these decellularized homografts that we implant now. And I also do that for the pulmonary side. And not because they are decellularized, because they are fresh, which makes a big difference, I think. But just for the audience, because we are now confronted to also go and replace the aortic valve with the Arise graft, which I completely not understand, and also not doing it, because we now already see what you beautifully shown, that they degenerate as well, because the scaffold itself is somehow immunoresponsive, and so it just don't work. But there is one exception, and I want to ask you experts about this, and this is if we use patches in neonates. For example, if you do the switch operation and we patch augment the pulmonary arteries. And if you have, for some reason, to redo that, it looks beautiful. It's autologous. We glutarate treat them. It's not necessary, but it's easier to manage, and they look perfectly healed in. So what is the difference now between a neonate and then all the others, where basically we see, despite its autologous, if we glutarate treat it, then they show this immune response and they calcify everything. So what's the difference in the neonate?
Well, I wish I would know, but as you know, I'm a surgeon. I'm not an immunologist, even less so a pediatric immunologist. I can only speculate. I'm surprised to hear that you say that autologous tissue heals better in neonates than in older children. But if you say so, that's the case. And why? Well, maybe the very young child, the newborn, has still more plasticity in the immune system in terms of dealing with its own tissue. I mean, in utero, there's always there's the separation line between the child and the mother, which is not complete. We know that now. Baby cells are circulating in the mother's bloodstream and mother cells in the baby and so on. So there has to be some kind of plasticity, of relaxedness, of relaxation in the immune system, in the neonate. Yeah? And maybe that helps. But that's only a very crude speculation. I'm sorry.
Thank you again.
But regarding the decellularized grafts, I just want to highlight this again here. Homografts, standard classic homografts with the cell still on, they work. They work for 10 years, and nobody has shown yet whether a decellularized homograft from CryoLife or from Hanover lasts longer than a normal homograft with the cells still on. There is no information on that. All we know is that the decellularized xenograft, the matrix valves here from Berlin, they do not work. They fail after a few years.
I'd like to come to this homograft example. I had the chance to work in Saudi Arabia, and one of these famous surgeons, Sohair Al-Halis, he treated all these patients who had a homograft inserted for 1 year with cyclosporin, low dose, just like this. The papers are published, there are no randomized trials, and they report that their long-term effects are much, much better, which would support your very, I say, energetic talk that the degradation is more important.
Yes, I thank you very much. I think that it does make sense, and still, honestly, I'm not sure whether it wouldn't be an option to put recipients, children, maybe not newborns, but older children, on some kind of low dose, whatever immunosuppressive regimen for some time. It may well make sense, and the risk, the side effects may not be outweighed by the potential benefit. So why not?
Just one very, very brief comment. It was probably the most refreshing talk I heard in the last decade, because truly, as a surgeon who has pledged his career to tissue engineering throughout the 40 years, you successively arrive at the insight that we are talking about something like atomic fusion. It always took for 50 years, and then again 50 years, and we need something now. And I'm in the same boat as you. We also started 25 years ago to demonstrate it's the immunity, the immunogenicity, stupid, in the bioprosthetic field. And we need something now, and we need to address these issues without giving up the dream that in 50 years we will have atomic fusion.
Well,
Thank you very much.
I want to thank you very much.